Hi, in this presentation, we will learn how to identify sick newborn and how to stabilize sick newborns. First of all, the most important thing when you take care about our newborn is to prevent infection from happening to the baby. So, hand wash is very important. So, we have hand hygiene by using alcohol swabs or hand wash with soap and water. So, hand wash with soap and water is very important. If the hand is visibly soiled, and there are 6 steps. One is washing the hand palm to palm, then washing the hand from the back of the palm, and washing the hand with the palms with the fingers interlocked, and fourthly, washing the hands over the knuckles, and then washing the hands over the thumbs, and then washing hands at the fingertips. So it should take around 40 to 60 seconds. First of all, we will assess the baby for any signs of sickness. So we have to differentiate between sick babies from non-sick babies. And sick newborns require a referral, preferably with the mother for continued breastfeeding. Newborn resuscitation program at the time of birth or subsequently may be needed if the baby is very sick, and which includes doing the initial step and stimulation of the baby. So the baby is apneic or the heart rate is less than 100, giving positive pressure ventilation and rarely chest compression and adrenaline and normal saline bolus also. So the NRP newborn resuscitation program training is a must for all doctors who take care of newborns. Now we will go through the emergency signs of sickness. If these signs are present, then the baby is at very high risk and needs the stabilization before getting admitted or referred. So these are like severe hypothermia, temperature less than 32 degrees Celsius, apnea or gasping, respiration, where the respiratory rate and respiratory distress, where the respiratory rate is more than 70, and severe retraction, continuous grunt, central cyanosis, where the saturation is less than 90, and shock or hypotension, where the peripheries are cold, capillary refill time is more than 2 seconds or 3 seconds, and weak and fast pulse. No urine output once in 10 hours after 48 hours of life, coma, convulsion, or encephalopathy, recurrent or severe hypoglycemia, which is 2 or more hypoglycemic episode, or symptomatic hypoglycemia, or blood sugar less than 25 milligrams per deciliter. Then we should look into priority signs of sickness. These are signs which shows that the baby is sick and needs immediate assessment, should be attended on a priority basis and may also need referral. And these are like, so we will go in a fashion like temperature, airway, breathing, circulation, like that. So first is temperature. So temperature should be maybe around 30 to 36.4, or the temperature may be high, like more than 37.5, a newborn with fever. Respiratory distress may be there, that is respiratory rate more than 60, but no or minimal retraction. Then irritable and restless or jittery, and refusal to feed. Then hypoglycemia, which is defined as a operational threshold of blood sugar less than 45. And actually, hypoglycemia is defined by operational threshold of plasma sugar of less than 45. But here we will take just blood sugar less than 45. And abdominal distension and severe jaundice that appears within 24 hours or after more than 2 weeks, or where the palms and folds of the baby are stained yellow. And the severe pallor and bleeding from any site, perinatal asphyxia, and no urine output once in 6 hours after 48 hours of life, or once in 48 hours in the first 48 hours of life. So after 48 hours, if there is no urine output in 6 hours, then that is a priority sign. And a delayed passage of meconium after 24 hours of life in term baby, and major congenital malformation like tracheoesophageal fistula, meningomyelocele, aortal malformation, and congenital diaphragmatic hypertrophy. Now leaving the emergency signs and the priority signs of sickness, there are babies who are at high risk for sickness, and that is also important to identify such babies. These are babies who may have problems like hypoglycemia or may have sepsis infection. So these are like preterm babies less than 37 weeks, or tiny babies with a weight maybe less than 2.65 kilos, and large babies where the weight is more than 3.6 kilos. And so there are risk factors for sepsis like rupture of membrane of more than 18 hours, spontaneous preterm labor, then chorioamnionitis with intraamniotic infection, then prolonged labor, unclean pervaginal examination, and perinatal asphyxia. So now we have identified the baby, and for identification, we need to assess the baby. So assessment is again can be done in the order of temperature, T, and airway and breathing, that is AB, and C is circulation, and D can be diagnostic. So first is coming to T. Using the back of your hand to have a rough assessment of the hypothermia, you can touch on the periphery or the fingers and the feet of the baby, toes of the baby, using the back of your hand. If they are feeling cold, then the baby may be in cold stress. If both the peripheries and central body parts are cold, then the baby may be having moderate to severe hypothermia. In that case, you can assess the temperature and you can place the baby under warmer and attach a probe, temperature probe, and record the temperature using digital thermometer as well. Check the blood sugar and sepsis rate because hypothermia may be associated with the infection. And rewarm slowly with servo-controlled radiant warmer, wrapping with a double layer cloth and kangaroo mother care or skin to skin care. Avoid using air conditioner and reduce the fan speed and close windows. Now, in severe hypothermia, where the temperature is less than 32 degrees Celsius, you may have to rapidly warm the baby till 34 degrees Celsius and subsequently slowly warm till auxiliary temperature of 36.5 degrees Celsius. And baby may need IV antibiotic and IV fluid for maintaining blood sugar. Measure the blood pressure also because neonatal shock may appear as hypothermia. The peripheries may appear cold in hypotension as well. So this is a chart showing the range of temperature, and normal range is between 36.5 to 37.5, and severe hypothermia is less than 32 degrees Celsius, where the outlook is grave and requires intensive care management. And between 32 to 36.5 is what is called the moderate hypothermia, and cold stress is between 36 to 36.5. So cold stress means only the peripheries are cold, the central is warm. That is a cause for concern, and we have to cover the baby and rewarm the baby. If there is moderate hypothermia, then again danger, and again we have to warm the baby. Now coming to the assessment of airway and breathing. Look at the breathing and count the respiratory rate. Now if the baby is not breathing at all, then stimulate the baby, or if the baby is gasping or slow breathing, that is respiratory rate 20 minutes or less, then it may be associated with the bradycardia or cyanosis, then not breathing or gasping. In that case, then it may be a hypoapnea also. That is, the breathing rate is very much less. So you may have to give oxygen. And apnea is defined as a lack of breathing for more than 20 seconds. And or less than 20 seconds if the there is bradycardia and desaturation. And check for respiratory distress, where respiratory distress is defined as respiratory rate more than 60 with chest indrawing, grunting, and nasal flaring. One of the three may be present. Then that is a respiratory distress case. Then check for central cyanosis, that is blue skin and tongue and lips. And that is the central cyanosis. Now, respiratory problem, if there is a respiratory problem, the baby may have a tachypnea, that is respiratory rate more than 60. There may be one of the three, that is retraction, nasal flare, or grunt. Plus, there may be desaturation, that is central cyanosis, and there may be apnea. So, rate should be counted in a quiet state, not when the baby is crying, and not immediately after feed. It should be counted over at least 1 minute. If it is high, then you may have to repeat it once more to confirm that it is tachypnea. And continuous grunting and low saturation indicate severe respiratory distress and needs emergency care. So, this is a picture of a baby with a chest retraction showing respiratory distress. How will you manage a baby with a respiratory problem? If the baby is not breathing or gasping, maintain the airway by positioning and placing the head correctly with a shoulder roll underneath, and suction the mouth and the nose if required. Stimulate to breathe and then administer positive pressure ventilation if the baby is not responding with Dagger mask or TP resuscitator. Attach the pulse oximeter and monitor the oxygen saturation. Provide the oxygen if saturation is 90% or less. A tactile stimulation can be done without CPAP if the apnea is present. Positive pressure ventilation with bag and mask or TP resuscitator can be done if there is gasping or apnea or heart rate less than 100. CPAP bar intubate and ventilate if the respiratory distress is there. Intubation ventilation is required if CPAP has failed, that is, the baby is not maintaining saturation even if a fraction inhaled oxygen of more than 60%, recurrent and severe apnea needing positive pressure ventilation, and severe acidosis with pH less than 7.25, and severe hypercarbia where PCO2 is more than 70. And in such cases, you may have to do a blood culture, CBC, CRP, which you repeat after 24 hours also. And CBC means complete blood count and chest X-ray. And you will need IV antibiotics as well as IV fluid. Now coming to a congenital malformation which causes respiratory distress, like the tracheoesophageal fistula, how will you identify a tracheoesophageal fistula? Baby in tracheoesophageal fistula will have respiratory distress from birth with excessive drooling, choking, cyanosis during feeding, and respiratory distress. So failure to pass a red rubber catheter beyond 8 to 10 centimeters from mouth, which can be documented even in chest X-ray. In that case, you have to refer the baby, transport the baby in forward position with continuous suction at the esophageal blind pouch until further management. So this is the X-ray of a tracheoesophageal fistula. You can see the red rubber catheter is coiled at around 8 to 10 centimeters, and there is some aspiration at the right side of the lung also, which can happen. And then congenital diaphragmatic hernia. So how will you differentiate, identify a baby with congenital diaphragmatic hernia? Baby will have breathing difficulty from birth with a scuppered abdomen. That is because the intestine has herniated into the left hemithorax. So you will hear bowel sound heard in the left hemithorax. Such baby needs intubation and support with invasive ventilation, and avoid bag and mask in such babies or TP resuscitator and mask ventilation. So if you are not able to do intubation, then you can shift the baby on oxygen by foot. Try to avoid that. Now cyanosis. Cyanosis can be peripheral, which can be found in normal babies, normal at birth. It indicates cold exposure. We can cover the baby and warm the baby. And the second is the central cyanosis, which means the lips and the mucosa is also blue in color. It indicates cardiac and severe pulmonary disease, and it always needs appropriate treatment and referral. So this is a peripheral cyanosis where the lips are pink, but the hands are blue. Here you have lips and tongue blue, and that is central cyanosis. So suspect cardiac disease if the cyanosis is there, central cyanosis there, and the saturation should be checked for congenital heart disease screening. And tachycardia, murmur, hepatomegaly, shock, chest X-ray showing cardiomegaly, and these babies may require echocardiography and cardiologist evaluation. So pulse oximeter screening is done at more than 24 hours of life to see for critical congenital cardiac disease. So if the pulse oximeter reading in either the right hand or either the foot is less than 90%, or if the pulse oximeter reading is at the right hand and either foot is between 90 to 95 on 3 separate measurements separated by 1 hour, or if there is persistent more than 3% difference in the right hand and either foot measurement on 3 measurements each separated by 1 hour, then that means the screen is positive or failing. Now, there is something called ductus dependent lesion, where the survival of the baby depends on the patency of the ductus arteriosus. In such babies, there will be central cyanosis, or baby may be in shock. And if you suspect a cardiac disease and the baby, that means the baby does not have too much tachypnea, but a lot of tachycardia, there may be central cyanosis, and it may be a ductus dependent lesion. In such cases, you have to stabilize the temperature, airway, saturation, blood pressure, and blood sugar. And baby needs monitoring for heart rate, blood pressure, temperature, and oxygen saturation. And in such patients, you may have to start a low-dose prostaglandin E1 infusion, alprostadil infusion. And and preferably it should be started after intubating and ventilating the baby because the baby may have apnea with prostaglandin infusion. So to prevent apnea, you may have to give intubation and ventilation. So you may have to reduce the oxygen exposure also because too much oxygen can close the PDA. So you may have to target a lower saturation between 85 to 90% in such baby. Then a rapid assessment includes the C, which is circulation, and also the consciousness and the convulsion. So circulation, if the baby has cold peripheries and the capillary refill time at the chest is longer than 3 seconds and the pulses are weak and faster, it may be shock. And regarding consciousness, if the baby is sleeping lethargic and unconscious and is not responding to any stimulus, it may be lethargy or unconsciousness. And regarding convulsion, repetitive jerky movement of limb, face, continuous extension, flexion of arms and legs may be generalized focal or multifocal. But most of the time, the newborns, 50% of times, they have a subtle seizure where the newborn just stare and there may be staring and repetitive blinking of eyes or repetitive movement of tongue or mouth. And that may be a convulsion. So again, speaking about shock, how will you identify the capillary refill time may be prolonged more than 2 seconds and the blood pressure is less than 35. And in such babies, you may have to give a normal saline bolus followed by a vasopressor infusion like dopamine in case of septic or non-cardiogenic shock. In case if you are suspecting cardiogenic shock, then dobutamine is the first option if the blood pressure is normal. Now, if the baby is not responding, non-cardiogenic shock, not responding to bolus and dopamine infusion, then you may have to give hydrocortisone, plus or minus adrenaline infusion. And in case of vasopressor treatment, you will have to use a central line. So better to refer the baby as soon as you give normal saline bolus if you are not in a NICU. Then capillary refill time is measured by pressing on the sternum with the thumb or index finger till your nail fold blanches, and then you leave and count till 1001, 1002, 1003. If the capillary refill time taken for refilling is more than 2 seconds, that is when you count by 1003 or beyond, the capillary gets refilled. In that case, it is a prolonged capillary refill time, suggestive of circulatory instability or hypotension. And baby may require normal saline bolus and intensive care. Now, lethargy and poor sucking. In a term baby who was feeding earlier, if lethargy and poor sucking indicates sepsis or neonatal illness or encephalopathy. In a preterm baby who needs careful assessment because it may be due to cold stress or just prematurity. Preterm babies may behave as if the baby is having lethargy and poor sucking. So in that case also, you may have to evaluate, may do investigation blood so that you don't miss sepsis. So blood culture, complete blood count, C-reactive protein, stat, and after 24 hours, repeat after 24 hours. Urine routine and urine culture, give first dose of antibiotics, that is IV ampicillin and gentamicin, and then refer if needed. So sepsis can be early or late, and late is after 72 hours, and it is usually from the community or from the hospital. Sepsis early within 72 hours is usually from the mother. In both cases, you may need antibiotics. And symptoms of sepsis are like lethargy, poor feeding, fever, hypothermia, vomiting, due to seizure. And then we come to seizure or convulsion. So in convulsion also, you have to manage the temperature, airway, breathing, circulation, give oxygen, monitor the saturation using a pulse oximeter, measure the blood glucose and sodium, calcium, and magnesium. And if you don't have your glucometer is not working, or if it is showing hypoglycemia, then low blood sugar, then you have to give a 10% dextrose 2 ml per kilo bolus, and then you start a IV fluid at a rate of 6 mg per kg per minute of glucose. And then you give 10% calcium gluconate after taking samples of calcium 2 ml per kilo in equal dilution with distilled water and slowly under cardiac monitoring. Now, calcium gluconate is a serious business. If you give it wrongly, fast, like a bolus, then the baby may have asystolia. So it should be given very slowly, and it should be diluted with a sterile water. That is the correct way, not the distilled water. So, and If the seizure persists, then you may have to give phenobarbital. Now, phenobarbital, if it is not available, phenytoin can be given. Again, it has to be given very slowly over 20 minutes because phenobarbital can also cause apnea and asystole. Now, rapid assessment D. D is regarding the diagnosis, and we very commonly measure the blood sugar and for looking at hypoglycemia. Now, saturation is also another diagnostic which we use commonly in newborn care, and then we check the blood culture, complete blood count, C-reactive protein, urine routine in urine culture, chest X-ray in case of respiratory distress and oxygen dependency, and echocardiography, and in case you are suspecting cardiac disease. Now, coming to hypoglycemia, the operational threshold where you correct the hypoglycemia is when the blood sugar is less than 45. Now, the nurses may report to you at a higher blood sugar, less than 55, so that you will be aware or vigilant about the possibility of having a hypoglycemia in the baby. Now, there are certain babies who are at high risk for having hypoglycemia. These are large babies of more than 4 kilo or maybe more than 3.6 kilo weight. Infant of diabetic mother, small babies like 2.6 kilo, 6.5 or less, and preterm babies where you may have to monitor the blood sugar at as per the protocol of your unit. And in our unit, we monitor at 1 hour, 3 hours, 6 hours, and then 6 to 8 hourly. Then prevent and treat the hypoglycemia. You may have to express the mother's milk. If the mother's milk is not available, then donor milk or formula feed. Now give 10% dextrose. If the blood sugar is very low, like less than 25, or it is low recurrent two times or more, or if there is a symptom like seizure, then you have to give a bolus of 2 ml per kilo, 10% dextrose, and start the IV fluid at a rate of 6 mg per kg per minute. Now, if an IV line cannot be established, then you can give 10% dextrose 2 ml per kilo through a nasogastric tube and then refer the baby. Now, monitor more frequently. If hypoglycemia is detected, then you have to monitor more frequently, maybe after 1 hour or 2 hourly, and then gradually taper the frequency of monitoring if the blood sugar is stable more than 55 to 4th hourly and twice, and then 6 hourly and twice 6 hourly and then 8 hourly. So slowly taper the monitoring of blood sugar. Now, failure to pass meconium and urine. That is also a risk factor. If the baby has not passed meconium within 24 hours with delayed passage, then you may have to suspect obstruction. You may have to clear the if the baby is term, then maybe. But in preterm babies, there may be a natural delay in passage of meconium. Maybe you can wait for the passage of meconium. And second is failure to pass urine in the first 48 hours. And that may also show that there may be an obstructive urinary tract problem or maybe a renal agenesis. Now, causes of recurrent vomiting. Ingestion of meconium-stained amniotic fluid can cause vomiting where you need a stomach wash. Then systemic illness, complete blood count, CRP, blood culture may be needed. That can also cause vomiting. Other causes of vomiting are congestive cardiac failure, raised intracranial pressure, metabolic disorders, and persistent projectile or bile-stained vomiting indicate that there is intestinal obstruction. And then causes of diarrhea. The infective diarrhea in neonates present as watery diarrhea or blood in stool. Now, infective diarrhea needs evaluation with sepsis screen, blood culture, and treatment with systemic antibiotics, rehydration with IV fluid, and ORS. Now, there may be transitional stool which may appear as diarrhea, which appear as yellow with white curd like material and watery, enough to resemble diarrhea. But if the baby has no other symptom and is feeding well and gaining weight, it should not be considered as diarrhea. This watery consistency is the result of undigested sugar in breast milk that acts as a laxative. Abnormal weight loss pattern. If a term baby loses more than 10% of its birth weight, and preterm baby loses more than 15% of birth weight, or if there is an acute weight loss in a day of more than 5%, then that is an abnormal weight loss pattern. Dehydration due to poor feeding in high-risk newborn, like a preterm, birth weight, or small baby, or sepsis or urinary tract infection, may be the cause of the abnormal weight loss. Now, you can give a supplementary feed with express breast milk and do lactation counseling and evaluate for sepsis, urinary tract infection, and If needed, start IV antibiotic in the case there is evidence of sepsis. So the common action to stabilize a sick newborn is very simple. First, you go in an order of temperature, airway, breathing, circulation, and drugs, diagnostic and drugs. And the first thing that you do is maintain the temperature. Keep the baby under radiant warmer and remove any cold or wet clothing. Second is clear the airway and breathing. So position and clear airway if required with suctioning, and the breathing. The oxygenation should be checked. So check the oxygen saturation using pulse oximeter. Maintain the saturation between 91 to 95 or more than that. Give oxygen to newborn with saturation 92 or less, and prevent and treat hypoglycemia. Refer all newborn with emergency signs after stabilization. Give fluids, IV fluid, if newborn is not able to feed, and give pre-referral dose of antibiotic before referral. Now let's see a case scenario where a baby has severe jaundice. So this is a preterm baby, 34 weeks, and the baby has yellow palm, and the baby is 4 days old, and baby has yellow palms and soles. How will you manage this baby, and what additional information and investigations are required? So maintain the temperature, airway, breathing, and circulation here also, and check the saturation and maintain it more than 95%, 90 to 95%. And circulation also you check by checking the heart rate and capillary refill time. Now start intensive phototherapy with 2 or 3 lights, keeping it close to the baby, and so that maximize the phototherapy time and area. Now optimize the feeding and improve the feeding, and maybe you can give express breast milk even by tube feed also, and monitor for encephalopathy, which is by which is indicated by poor feeding and lethargy. When palms and soles are yellow, which indicate that the jaundice is severe and pathological, and the baby has at least one risk factor, that is here it is prematurity. In that case, do urgent serum bilirubin, mother's and baby's blood group and blood sugar, and plan referral. The baby may require exchange transfusion also. So pathological jaundice is defined as jaundice within 24 hours of life, or a bilirubin very high, like more than 17 milligram per deciliter. If there is staining of the palms and yellow staining of the palms and soles, and above, and the bilirubin value is more than phototherapy and exchange transfusion range, or it persists of the bilirubin value more than 10 milligram per deciliter, persists beyond 2 weeks of life. And this picture shows yellow palms and soles staining, and the serum bilirubin levels are checked and treated as per the phototherapy charts. And you have the American Academy of Pediatrics chart and NICE chart. This is the old Academy of American Academy of Pediatrics chart for phototherapy, and this is the chart for exchange transfusion. So to summarize, for stabilizing a newborn, you have to first assess the baby to identify sick newborn. You may have to do the newborn resuscitation program if needed, if the baby is very sick, and you have to evaluate for the cause and severity, and then give the first prompt treatment, and then referred if required, and then refer if required. So thank you for the patient listening, and hope you understood how to stabilize a sick newborn.